All right, well, we're here with Dr. Roger McIntyre, and we're going to be talking about one of the talks he's going to be giving at this year's Congress. And this particular talk is called Unveiling the Therapeutic Potential, Evidence Supporting the Use of Psychedelics for PTSD, SUD, and Other Indications. And so, as a quick overview, psychedelic drugs, either with or without psychotherapy, have shown to be a promising therapeutic tool for treating trauma-based disorders like PTSD and a variety of other indications like depression and substance use disorder. In this invigorating and provocative talk, Dr. Roger McIntyre will discuss the current evidence surrounding psychedelics for PTSD, SUD, and depression. This talk will give you an up-to-date understanding of the latest research in psychedelics for psychiatric disorders. Hello, Roger.
Andy, great to be with you.
Tell us a little bit about this talk and why people might want to come.
Andy, you really set it up really nice for me, and thanks for that, and great to see you and work with you, and looking forward to Congress in a very big way this year. You know, Andy, as I think about the media, the public, the scientific, really the global interest in psychedelics has only been trumped by the Eras Tour by Taylor Swift, quite frankly. There's so much interest and excitement around psychedelics, and look, it's deserved. Our patients deserve hope. We deserve a new frontier, and there are some really interesting lines of research in the psychedelic area that gives us the reason to believe. I think, first of all, Andy, what I'm going to be spending some time on is definition. Psychedelic now is a tent that's so big. It began with, of course, the famous serotonergic psychedelics, LSD and psilocybin, but it's been extended out to include other mechanistically different agents like ecstasy, MDMA, and even ketamine and ketamine derivatives like esketamine. My presentation is going to focus more on the classic serotonergic psychedelics. We're going to review the data with respect to where the leads are. The best leads now are in major depressive disorder, especially TRD, treatment-resistant depression. And as you know, Andy, there's some really interesting replicated phase 3 data now with ecstasy in PTSD, which we'll certainly cover. Now, as always the case, what I'll cover, Andy, is we'll get into some of the interpretations of the data. We have to always approach data with a critical eye. And I'll go through some rather controversial topics, or at least they're controversial for now, that being how integral is the trip to the drug actually working? Relatedly, how integral is psychotherapy? Do we need, is this psychedelic assisted psychotherapy, or is this psychotherapy assisted psychedelics? I'm not sure which one it is. We'll talk more about it.
Right.
And then we'll also get into some of the methodology, not the boring sort of day-to-day methodology of the study, but really important things such as functional blinding and losing the integrity of blinding, and how should we interpret the data. So it's going to be a real look in a very brave way at the data, but brave in the sense of looking at some of those controversies that I think will provide a perspective for people to understand the literature. So I'll do the best, keep it up to date. It's going to be a really fun talk.
Yeah, I agree. And there are a number of strands here, if you will, to be examined. I know you have been writing quite a bit on this topic. I've really enjoyed your recent commentary on the questions around this. Is how much is the trip necessary? There's a lot of evidence in the neurobiology and the biologic mechanisms of what these drugs are doing, independent of any form of external psychotherapy or things like that. You know, these studies do have very different methodologies. I've reviewed a number of these protocols, and I'm actually the chairman of two DSMBs for these trials. So I'm aware of some of the methodologic issues that you've alluded to, but I have to agree, there is such excitement around this, and both medically, scientifically, but also in the popular press, as it should be whenever we have something new, potentially effective. And I think the concept of them working pretty rapidly is also exciting. Do you agree?
Yeah, I do. And, you know, they do work. They're rapid. They're more faster acting. They help patients with difficult to treat, very serious mental illnesses. And the opportunity to take a treatment more intermittently or sort of episodically rather than taking it every day is certainly appealing to most people. And certainly that's something that we're going to be covering. We're also going to get under the hood a little bit and look at what we think to be happening in the brain when you take these treatments. And I think really what we're going to talk about is points of convergence with conventional treatments, but also some areas that might be slightly different. And I see this as part of this new chapter, Andy. I know we've talked about this before. I think there's going to be 10, 15 years from now, we're going to look back and say, what were we thinking back in those days? Expecting patients to wait 2 months for drugs to work or 4 weeks for drugs to work, So it's part of this new sort of zeitgeist in the field. But I think also, Andy, I think there's a philosophical issue which I'm going to also address in the talk. And that is, are these drugs being developed for medical purpose, or are they being developed for recreational or cosmetic or lifestyle purpose and spa purpose? And, I don't think we have the luxury to be ahistorical. We've already seen peril with respect to cannabis and how cannabis was developed. It was kind of conflated medical and lifestyle. And again, I'll keep it focused on the science, less on the politics. I'll just stay in my lane on the science. But I think it's going to be important for us to really understand it. And if we wanted to use these medications medically, they have to be safe and effective, but they have to be supported by adequate and well-controlled trials. And we're going to get into some of the nuts and bolts of that.
Yeah, certainly. And if they are, when they are rolled out, I should say, there's going to be certain issues just practically for clinicians who want to incorporate this into their practice. If they are using one of these substances that does cause the trip, of course, you're going to have facilities for somebody to spend the whole day there. And what kind of staffing are you going to need? What about the scheduling and regulatory issues? Currently some of these are C1s, Schedule 1s. That requires a special license. And the history of that, you're right, and the politics are very interesting. LSD and some of these drugs were originally developed for therapeutic purposes, and then became co-opted, if you will, by the hippies and others. And that led to a political backlash, and that's where the scheduling came in, of course. But I think that it's really fascinating, these number of different issues, but you're right that it all starts with the data. We need evidence that they work, and then we'll have to figure out how to use these tools properly. So I'm looking forward to this talk, Roger. Also, you and I will be giving a talk during the main Congress on rapid-acting antidepressants. Yeah. We won't be including the psychedelics because you'll be doing that in your other talk. But there's still plenty of other drugs for us to talk about.
Oh, for sure. So, I'm looking forward to it. It's going to be fantastic. It'll be a lot of fun, and we're going to be, just being unvarnished with the data and try to really try to find where the data takes us and try to leave the emotion about it to the side and just let the data speak. And it's going to be a lot of fun. And look, this is a highlight of the year. This is a wonderful conference, and I'm looking forward to seeing lots of good friends and colleagues there as well.
Could not agree more, and we hope to see you all there, either in person or virtually. Thanks for listening.